Thanks for having me. I do have some disclosure which are relevant to this talk. So the question was, is MIS TLIF relevant or a niche? So as any MIS procedure, it's the same goals as open procedures. So you want to decompress the spine if you need to decompress, stabilize, and realign. And Wilty described the approach in 1968. Basically, it's simply a muscle splitting approach, which we preserve the supraspinous ligament and makes sense that the patients have less pain and do better. So history of TLIF, Harms described this in 1982 to avoid nerve retractor from the PLIF. Foley took this a little bit further back in 2005. We described a case series of about 49 patients where he reported good outcomes. And there were some early concerns. So naysayers said that does not fuse, too many complications, no long-term clinical outcomes. And frankly, it was hard in the past because the equipment was not as good as we have now. So if you do a quick Google search on MIS spinal retractors, you'll see a whole plethora of options, a whole plethora of cages. In terms of the retractors, you have either, so better cages and delivery systems. So you get static cages, oblique cages, crescent, expandable, height-wise, width-wise, lordotic-wise, and a whole variety of materials, including PEEK, titanium. And I think where the real improvement came was the cage delivery systems where you could insert the cage through a very small corridor. And also you could insert graft in there too, also through a very small corridor. So what matters most is the clinical data. So, you know, three things we looked at, blood loss, length of stay, and patient-reported outcomes. I think it's good to see a bird's eye view of what we knew back in 2010 and what we know currently. So there's a nice study back in 2010 where Isaacs looked at about 6 or 7 cases where they compared MIS TLIF versus open, and recently also a systematic review, also with a meta-analysis in 2019, looking at all the studies comparing MIS versus open TLIFs. So if you look at blood loss, in 2010, we found that consistently that blood loss was less in all these studies that we looked at. So if you looked at the highlighted portion, every study that we looked at consistently showed that blood loss was less even from 2010. So again, so 2010 found out consistently that blood loss was less. And if you look at 2000 current data that that again, on the current studies, they looked at about over 30 studies where, again, using current data, that the blood loss was again 2019, where we have more studies and longer term data. So in this case, MIS TLIF wins. So if you look at length of stay, again, looking at the early outcomes in 2010, we found out that also back then consistently that length of stay was less.
Dr. Kim, would you like us to advance your slides for you?
Yeah, if you don't mind, I have a long lag. I don't see the remote control.
Yeah,
so current data, again, looking at the studies that, again, with the current data that length of stay is, again, consistently less with the MIS group. Please advance. So again, MIS TLIF wins in the comparison. Advance. Now, what we really care about is patient-reported outcomes. So if you cone down to different parameters, next slide. So 2010, you know, data is not much out there, but you do find out that in a short-term outcomes, about 2-3 years, that the results are comparable both in the open and the MIS TLIF group. Next slide. Next slide. And if you look at the current data, we found out that if you look at ODI and VAS scores, they are very similar or the same in the open versus the MI group. Next slide. So MIS TLIF and open TLIF clinical outcomes are similar in conclusion. There's a suggestion that in obese patients that the MIS is a better clinical outcomes in studies, and fusion rates are also found to be very similar. Next slide. So a real downside, as Dr. Key Kim mentioned, is that radiation is significantly more in this approach. However, with improvements in navigation and robotics, I'm confident that this will be less with time. Next slide. And surgery evolves. So if you look at general surgery and orthopedic surgery, it's pretty rare that there's an open cholecystectomy or an open meniscectomy anymore. Next slide. If you look at spinal surgery, again, discectomy, traditional discectomy, where you go down, take out the disc, make a big incision without localizing. Patients do overall well. However, the whole goal of this is to minimize the collateral damage. Next slide. And 70s and 80s, we moved on to localizing the incisions and also using the microscope. Next slide. Go into tubes. Next slide. And endoscopy that we'll talk about in the future talks. Next slide. So MIS is here to stay. I don't think it's a niche or a fad. I think you'll definitely here to stay. So in conclusions, it's more and more relevant, and in my opinion, it's the best potential to become routinely outpatient for lumbar fusion. So sorry about the technical issues, but thank you very much.